All right. So again, I don't exactly remember what we talked about seizures. Okay, but seizure is a basic neurologic episode of too much stimulus or too much electrical activity going to the brain, right? So a seizure is basically our hard reset button. Okay, it shuts the brain down for a minute, wakes it back up, reboots it, brings it back up in order. Hopefully, okay, it's back to normal when it starts. Okay, if it's not, we keep having recurring seizures. Okay, and they can be dangerous because they can cause brain injuries. All right, so there may or there may not be convulsions. There may be just as simple as an eye flutter, okay, with a period of ataxia or no speech and like no muscle movement. They may just be like staring off into space, right? We call those absent seizures. All right, but we have two main groups. They're both generalized and partial. Okay. No, are we not gonna? There we go. Okay, so generalized seizures are abnormal electrical discharges from the larger areas of the brain. All right, they're just extra impulses that pop off when they're not supposed to. All right, kind of major irritants. All right, you may see severe twitching of all the muscles that they're going to depend, go anywhere from 30 seconds to several minutes. All right, when you get on scene and you ask someone how long they've been seizing for, they could tell you 5 minutes, and it might have only been 15 seconds. All right, but in an emergency situation, if we all sat here and sat in quiet silence for a minute watching someone shake, it's going to feel like an hour, right? So hopefully you get to witness the seizure. You can time it. All right, try to start counting in your head so that you know how long they're lasting. All right, they're going to have a postictal period. Okay, at the end, that's kind of the reset period where they just kind of come back in. They slowly reacclimate to their environment. Okay, they may come up angry, they may come up swinging, depending on the person. All right, some people come out different than others. All right, so just be careful. Okay, this is, like I said, partial seizures. All right, so there's usually no change in consciousness. They usually know it's happening. All right, their arm could be go numb. They could get dizzy, weak. They could have the visual changes, the spots, the blinkies. Right, they might say they see stars. They may say they smell violets, or what's the other one? Jasmine. A lot of people say they smell like jasmine or flowers. They get like a floral smell right before they have a seizure or as they're having it, but that's all they smell. There may be some muscle twitching. It's not as bad as the full like tonic-clonic generalized seizures. All right. So then we have the complex partial seizures. All right. This one you'll definitely have the alternate mental status. Okay. Usually they form or they start in the temporal lobe. All right. These are the ones where they're going to be either smacking their lips, their eyes are going to be jerking all over the place. Okay. They may have just one limb flailing. Okay. Because it, depending on where that impulse comes from, all right, is what's going to be moving. These are the ones that may actually come up swinging. All right. Because they may hallucinate when they come out of it. All right. So just make sure you're careful. Okay. Be careful around them. Like I said, they might hallucinate. They might come out fearful. All right. They might have that repetitive behavior, right? That lip smacking might just happen all the time. Okay. We have one up in Red Hook that does that a lot. She smacks her lips and her right arm shakes. All right. Auras. People who have seizures sometimes have auras. They tell you they see it. All right. Just be advised that there's possibly a seizure coming behind it. Okay. Usually, if they know they're about to have it and they can work their way out of it, sometimes they can, sometimes they can't. All right. Or they'll lay themselves down because they know it's going to happen, or they'll tell you that I'm about to have a seizure. Like, I see my aura. All right. It doesn't always happen. Not all patients have them. It's a thing. All right. If you hear them talk about it, just be prepared. All right. How do we deal with people who are actively seizing? You can roll them on their side, right? What else can we do? Right, we let them seize, right? We don't restrain them, we don't stop them, we don't try to hold them down. Obviously, do not put your fingers in their mouth and try to hold their tongue, right? In case they clamp down, you lose 2 fingers. All right, you let them seize, roll them on the side so they don't aspirate if they're starting to vomit or foam comes out of their mouth. If you're already on the stretcher and you don't want to roll them on their side or can't because it's not safe, suction. All right, get the suction ready. You can do the same thing. All right. I feel like we just talked about these. All right, so generalized seizures or your tonic-clonics, all right, are the chaotic muscle tones. All right, they can go limp, they can be spastic, they can continue to shake, they can shake all over. All right, they may stop breathing. All right, there's a whole lot of wonderful things that you have to deal with. Okay, so with these patients, again, we keep them safe. We do our ABCs, right? If they're not breathing, we're gonna breathe for them. All right, for whatever reason, if they stop breathing long enough, their heart stops. All right, we gotta do CPR. Okay, you might see both arms or both legs go to time. They may just flex out, they may flex in. All right, they don't have to shake, could just be that posturing. All right, and it may last up to 3 minutes. All right, you may see it go in and relax. No, we don't do grand mal, petamol, tonic-clonics. We don't do any of that stuff anymore. They're just generalized. Yeah, absence seizures we kind of do, only because you want them to be on the lookout, right? Because there is no actual visual cue for an absence seizure other than you have to be staring at someone and all of a sudden they just go like this. And you might see like their eye kind of twitch back a little bit and like you're talking to them and they're just like, right? Like, so they're having that absence seizure. I know you guys didn't get to see any of that, but they stare off into space. All right, they may be tachycardic. They're going to be hyperventilating. All right, sweating. You might have to suction. They usually foam. There's usually a lot of saliva. Okay. Again, seizures are different, anywhere between 30 seconds to 5 minutes to 7 minutes. All right, depending on the patient. There is no rhyme or reason to them. Okay, they may have one, they may have several. All right, I had a lady out in Dover. Did I tell you the Dover lady story where I wanted to beat the crap out of the lady driving the car? So, okay, so the lady in Dover, she's I think 30. She has a history of seizures. She has a couple every now and then, whatever. Most people with a history of seizures kind of have their seizure. They come out of it, they're good to go, right? They don't want to go to the hospital. They kind of just do their thing. They know they have them. It's a pain in the butt. They don't. Hospital doesn't really do anything for them except monitor them to make sure they're not going to have another one for a little bit, and then they usually send them home anyway, right? There's not much you can do for seizure activity. So they were out in Poughkeepsie. It's 9:30 in the morning. She had her first seizure at 9:30 in the morning. Okay, whatever. They were driving around. She was like, "No, I'm good." Like, blah blah blah. Let's keep going. All right. 3 hours later and 10 seizures later, she is still in the car in Poughkeepsie, and they're like, "Well, we should just go home." So she drives her to Dover. Now she is in Poughkeepsie near 2 hospitals. This woman has now had 10 seizures in a 3-hour period. And they thought instead of driving her to a hospital that was 3 miles away in either direction from where they were, that they would drive 40 minutes from Poughkeepsie back to Dover. As they were pulling up into their parking lot, she decided to have her, I think it was 13th seizure of the day that they told me she was having. And then they called 911. Now, when I found out the history, I literally looked at everybody on there and was like, and none of you thought that it was appropriate to take her to the hospital when you were in Poughkeepsie. There were 2 of you in the car and you just let her seize 13 times and you brought her all the way back out here. And they'll just kind of looked at me. I'm like, I have been to this house more than enough times. I know every one of you by your first names. I was like, none of you, every one of you thought this was a good idea. Well, I'm like, nope. I was like, let's go, dear. Like, so, I mean, and she was recurring at this point. Like, she seized from the time I saw her in the car. I gave her IM Versed. It slowed down for about 10 seconds, just enough for me to get the board under her out of the front seat of the car onto the stretcher. She immediately started seizing again, gave her more Versed, enough to get her into the truck, started seizing some more. I gave her some rectal Versed, and then she was out for the rest of the trip. So I now know what works for her. I do not ever want to have to do rectal burst on her again, but I now know what works for her. Right? So, but I was more mad at her, at the people with her, because they let her seize for 3.5 hours over 13 times, and they were near a hospital that they could have gone and gotten her stabilized and then come home. Right? But again, by the time I got her, she was in her recurring seizure phase where she just kept seizing over and over and over again. That's status epilepticus. Yep. So that's just recurring seizures that won't break. Okay. So the absent seizure is what we used to call the petite mal ones. All right. The generalized is what we used to call the grand mal, or the focal motor, or the tonic clonic. All right. They keep changing the names on them. Mark, why do they keep changing the names on us? Science. Sure. Let's call science. All right. Maybe it's easier to, instead of grand mal, petite mal, things that sounded like, we'll just call them different things. I have no idea. Right. So the absence ones, like we said, these ones are usually pretty short. All right. There's usually not a very long postictal period. They usually come right back out of it and kind of know already what's going on. It's almost like it's like a brain fart. It's like you're old, like grandma, she just stares off for 2 minutes, then comes right back to the conversation. It's kind of the same concept. Okay. Like I said, they're very hard to notice unless you actually see like the involuntary eye twitching. All right. We just talked about this one, the status epilepticus. All right. Any seizure lasting more than 5 minutes that doesn't break, okay, will turn into status epilepticus. All right. And then any seizure that lasts, well, any group of seizures that last up to 30 minutes without regaining consciousness also counts as status epilepticus. All right. So if you have a seizure, you come out postictal, and then you can talk to me again, and then you go into another one. All right. That's a second independent seizure. All right. These are seizures that you seize, you're postictal, you're still unconscious, right? In the next minute, you start seizing again, and this happens for up to 30 minutes. All right. So this is the one that's dangerous. Okay. This is the one that can cause brain injuries. You can become anoxic or hypoxic. Okay. So we have multiple different types of seizures, right? We have epileptics or epilepsy. All right. Usually the bright lights, the flashing strobes, anything like that. Okay. Sets them off. All right. Those are congenital. They're from birth. Okay. You can have structural. All right. Tumors, whether they're cancer or not, infections of the brain, scar tissue from previous brain injuries, any type of head traumas can develop seizures, right? Because that scar tissue, past strokes, all right, can cause that interrupt in the electrical discharges. Okay. Metabolic reasons, right? That hypoxic events, okay, abnormal blood glucoses, all right, or other body chemicals. Okay, hypoglycemia, poisoning, overdoses, withdrawal usually comes with seizures, especially from alcohol. They get the tremors. All right, but if they're a severe alcoholic, they can go into seizures. All right, those tremors can develop even worse. All right, and then usually in our kids, the bottom one is our children. All right, usually if a children has seizures, it's because of the fevers. All right. So we'll talk mostly about epilepsy because that seems to be the most common form usually. All right, these are a couple medications. Okay. Recognize them. You don't really need to know them by name. All right, but if someone tells you that they are on any of these type of medications, just know they have a seizure history and they might have one in your presence. Okay. Keppra, Dilantin, Depakote, and Klonopin seem to be the four most common ones that we see out there. All right, I don't really see too much phenobarbital anymore, or the other ones. I don't see Topamax very often, and I don't see the carbamazepine. Not to say you won't see them, but the other four are the ones that you see more often. Levetiracetam is the Keppra. Okay, that's the most common one I see, and the clonazepam. All right, but that also has other options, other effects. So this one's not always used for seizures, but it yeah, yeah. So we talked about this right with the other slide. So any abnormal brain cells, tumors, infections, previous scar tissues. All right, so that's why this medical history is so important, right? Certain blood chemicals we're not going to know, all right, unless it's blood sugar. Okay, we're not going to know anything else unless they went and had blood work, and the doctor calls them and says your blood work's abnormal, go to the hospital, and they call you. Okay, and then they tell you, hey, like the doctor told me that I have crazy amounts of blah. All right, whatever that one is may cause seizures. I'm not sure the other blood chemicals that cause seizures. I know the one I get called for most often is high potassium. Okay, which will cause cardiac problems. Certain poisons, all right, overdoses they may seize. All right, prescribed medications, certain overdose medications can cause seizures. All right, and then we talked about the febrile stuff. Okay, so why do we tell you all that? Because we want you to know what a seizure is, so that when you see it, you know what you're doing. All right, and whether this seizure is worse than any of the other ones. All right, especially if you've witnessed multiple seizures from this patient at a time. Okay, they turn cyanotic. Right, so if they're cyanotic, what do we do? Right, we give them oxygen. Okay, so you're definitely going to hear some very interesting sounds when people are having seizures because they don't breathe appropriately. All right, but as long as they're seizing, you know, let them seize, and when they're done, control the airway. Right, you don't want to be in the middle of it. You don't want to get in the way. You don't want to get punched in the face. I've had people get kicked in the genitals. All right, just let them do their thing. Keep them as safe as you can. Keep yourself safe. All right, diabetics who have seizures. All right, if they go up or down, okay, they're gonna burn through the sugar they have, or they may not have enough, and that's like why they're going to seizures. Sometimes too much, too little, you can go into diabetic coma. The coma can go into seizures. Okay, so if they have a history of diabetes, we're gonna take their blood sugar anyway, but we always have to be careful because we may have to actually give them sugar. All right, just so that it might be all they need. Right, but we just want to make sure they have enough for the next seizure. All right, and again, our protocol allows it. So we are going to, usually every time I do a set of vitals on a diabetic, I'll do a blood sugar, especially if it's a diabetic crisis or if they're having seizures. All right, just so that I know, because you don't want it to fall critically low or go critically high, especially if you're giving them sugar, like if you're giving them glucose. All right, you want to make sure that you're not spiking them out. All right, and then are there any other reasons for the seizures? Okay, this goes back to the trauma test, right? The essay question on the trauma test. All right, my guy was having seizures in the bed, but the seizures weren't because he has a seizure history. It's because he fell and smacked his head 2 days before, and they picked him up, put him back in bed, and no one ever said anything, right? Until he started having problems. Okay, so pay attention. All right, if they didn't lay down or they weren't in bed or they were standing and they fell, what did they crack their head on? Did they crack their head? Did someone catch them and lay them down? Right? Is there a possible head neck injury? Do we have to do C-spine? All right. Most everybody will be incontinent. I have not found a person who had a real seizure that did not urinate themselves. Okay, it is just a thing. I have seen plenty of seizures, and everyone that has had what I will call a real seizure, because there are some out there I swear are faking it. Because when they go postictal and you lift their head up, they go. Ay. So I have a couple dramatic people who I feel are faking seizures just to get out of their residence when they feel like it. But we won't talk about them. Okay. So when I say a real seizure, most of them will be incontinent. Usually urine. I've never seen someone actually defecate themselves, but most people who have a seizure will at least urinate on themselves. Not always. Right. You know someone who doesn't? No? Okay. I mean, it could be different for everybody. I'm just saying in my general experience, most people who have had a seizure have also at least urinated themselves most oftentimes. And some, I'm not saying it's a big old, like huge puddle, like, but there's at least, you know, sometimes there's a little couple speckles, but most times. All right. So the postictal state, all right, the muscles relax. They should be flaccid. Okay. In postictal state, you should be able to put someone's hand above their face and they should come right down and smack themselves in the face. All right. If they do one of those, okay, they're not really unconscious. All right. So sometimes they're labored breathing. Again, it might be because there's phlegm. It might be there's sputum back there. It could be because they aspirated on something. All right. Most times they come right back into possible normal breathing. All right. Depending on how bad the seizure was and how often the seizure is, remember we talked about how respiration off gases. Okay. These people wake up, they're sore, they're tired. All right. It's like they just ran a marathon. We're in a 5-round prize fight in the UFC. All right. They've used every muscle they didn't know they had. They've used all of their energy stores. Okay. Their blood is full of lactic acid, right? Which is what they go and they check to make sure you had a seizure. They'll check your lactic levels, right? Mark? Yeah. Okay. Just want to make sure. Like you make me nervous. Like I usually say these things, I'm confident, but now I'm like, I'm double checking myself across with the encyclopedia over here. Okay. So that lactic acid, right, in the blood can get blown off as carbon dioxide. Okay. So the body will metabolize it. So they'll usually be hyperventilated or hyperventilating, trying to blow off that extra stuff. Okay. As the liver slowly gets all that stuff out, right, their breathing will come back down because their body's going to return to that homeostatic environment. They're going to readjust their pH levels, all right, through all that wonderful microchemistry that we don't need to know about, right? So postictal may also look like a stroke, okay, because of that flaccid nature. Only one side of them might be flaccid. They may have other muscle tone, okay? So just be aware, all right, if they make sure all of the muscle tone returns, okay? Otherwise, there is some other resulting neurologic event may be happening. They will be lethargic and confused in the beginning. They may be combative. Like I said, just take care of yourself, okay? Make sure you're safe, then make sure your patient's safe. All right. If the patient doesn't come out of it normally, all right, then we're going to worry about hypoglycemia. Then we're going to worry about sepsis. Okay. Then we're going to worry about other medical possible traumatic causes for the seizures, right? But if they've had a history of it, okay, they should come out of it. And the family members should know. It's usually not a new onset thing. People who have seizures have them. Families are pretty comfortable with it. Okay. Seizures can often be mistaken for syncope. All right. But again, you may or may not, like if you didn't witness the seizure and you just see them come in and they're passed out, you may have thought they just collapsed. All right. So you may get a call for unknown patient down, patient collapse, syncope, or whatever, and it may end up being a seizure call. Okay. So just be careful. All right. Again, like I said, seizures don't discriminate where you are, when you are, where you're at, what you're doing. Like you could be sitting in the chair nice and comfortable and have a seizure. I could be standing around here and fall out right now and start shaking. All right. It doesn't matter. You could be driving and have a seizure. Okay. So we have to worry about that kind of stuff, right? We have to take all that into consideration for our treatments. All right. And fainting is not postictal. All right. They're not the same. Someone faints, they're not postictal. Like there's a reason they fainted and it's different. All right. It's not the same. It could be hypoglycemic and it could end up being the same cause, but they're not medically the same thing. All right. So now what makes all of that different from altered mental status? Right? So we just talked about seizures and strokes and hypoglycemia and all that other good stuff, right? And then we still have this third level called altered mental status, right? What is altered mental status? Anybody? Anybody on Zoom? Anybody in here? What's altered mental status? It doesn't have to be thinking clearly, right? What is it?
I believe the book answer would be unclear mind and or unconscious.
Right. Unclear mind or unconscious. Basically, any deviation from your normal baseline. Okay. So my grandma, well, both of mine are dead, but okay, grandma, all right, who has dementia, all right, who's confused all of the time and has a GCS of 14. All right. If I walk in, she's not altered because that's grandma's baseline, right? But if she starts not being able to talk or, starts being, I don't even know how you consider what more confused of a dementia patient is, but the family says she is more confused than normal right now. Okay. Or if normally she can tell a story and now she's just like gibberishing half a word out at a time. All right. So now, her verbal's down to like a 2. Okay. And everything else is the same. So she's going to be like an 11 now. All right. That's altered. Okay. So you have to take their normal baseline into consideration and then go from there. All right. Again, the patient is unconscious or not arousable. They're definitely altered. Yes, ma'am.
What about somebody who's like talking but not making sense? Will that count as altered mental status?
If their normal baseline is like a GCS of 15, like where they're, so she asked if someone's talking gibberish but not making sense. And yes, if their normal baseline is normal.
Yeah.
Right. If it's like you or me or someone that has no neurodeficits, no anything else, and they start looking at you and they start saying the sun is black and tomorrow it's going to dig a hole and stuff like that, then yes, that's altered. Something just happened. Okay. But so it depends on what their normal baseline is. All right.
Okay. Thank you.
You're welcome. So again, blood sugar rears its ugly head again, right? So hypo/hyperglycemia can cause altered mental status. Too high, too low, right? They can go one way or the other. All right. So again, hypoglycemia mimics strokes and seizures. They may be paralyzed on one side or the other, depending. They may be in a straight diabetic coma snoring, right? What's the matter, Joe? You got that frowny look on your eyes that you're like trying to think of something. They can come in a stupor. Yep, they have that drunken stupor. Okay, right, but it's not always just a drunken stupor anymore, right? I mean, I hate using our resident brand new diabetic in class, but my man was in class eating a lollipop, having a good time, and his blood sugar was 600 something. Okay, he even remembered he's proud of his number. All right, most people at 650 are going to be drooling on the floor, snoring. All right, so his body was compensating pretty well for him. Okay, but he didn't look right. He didn't look drunk or he wasn't in the stupor. I've had people at 40 do the same thing he was doing, sit there talking to me like a normal. I had one lady at 20. 20 is the lowest one I've seen, where they were sitting in a chair talking to me like nothing was wrong. Okay, so it's not always that stupor presentation, but it is a good solid starting point. All right, so stroke patients, as long as it's not a severe bleed in that cortex, in the occipital lobe, right? No, that's not right. Can communicate. Okay, like Joe said, patients with hypoglycemia will usually be in that drunken stupor. All right. If they're alert at all, it's usually like an altered mental, confused, lethargic, slow. All right. They're running out of gas, basically. Think of sugar as the gas. All right. Sugar is what causes our metabolism. All right. It's what gets broken down into energy. Okay. So diabetics have insulin. Sometimes they may take too much. Sometimes they may take the right dose and then not eat something and then it bottoms them out. All right. So we always check people's sugars. Again, we talked about sometimes it jumps into seizures. Okay. Their mental status isn't going to improve until they have sugar. All right. It's going to take a couple minutes for the body to metabolize that sugar, and then they usually will pop back around. All right. You might see them, like Joe mentioned in the quiz, like after the break, we'll take a look at the quiz. Okay. They might be flushed. They might be diaphoretic. They might be complaining of chest pain. They might be tachycardic. Okay. They might have all of those symptoms. All right. And a little bit of sugar and all that stuff comes right back. All right. Again, I've actually had a couple of these where the cause of the MVA was a diabetic who sugar crashed, and they even knew it. They had the insulin pump right on him. He's like, I had my lunch. I was about to try to eat it. He goes, and then it just passed out, drives off the road. Usually hits a tree, but they're usually driving so slow at that point. Like, I never had a real serious diabetic crash, but which is lucky, and they're lucky. Most of the times they know it's coming. That you can feel it when your sugar starts dropping, especially if you deal with it on a regular basis. All right, we have this thing called delirium. This is one of the harder ones to kind of pinpoint. All right, because it's a symptom. It's not really it's not a diagnosable disease. All right, and there's excited delirium and there's delirium. All right, excited delirium is where the patient is a physical danger to themselves or other people around them. There's no way to bring them down. Okay, they're way out there. All right. It can have physical or mental interactions. All right. It can be caused by an infection. Okay. Medication changes, especially people with mental health problems. All right. They're nothing. You shivered, but your neck twitched, and I had PTSD. I had PTSD from you going, Okay. I know. That's what I said. You shivered, but it like made me look for a minute. All right. So the changes in medication, right, can cause the levels in the brain of certain chemicals to get out of balance, which can cause people to have adverse reactions. All right. Hypoxia obviously is going to be some sort of brain injury. All right. Usually they're reversible. Most oftentimes we're going to sedate them because, again, they're going to be probably a danger to themselves or the people around them. It usually comes on like this. It's very rapid, or they may be good, bad, worse, depressed, high, low, anxious, like they're all over the place. All right. There is no rhyme or reason. Most people think they're drunk. Most people think they're on drugs. Most people think they overdosed on something. All right. They're very disorganized. Okay. If you watch, what was that one show? It was the one in Louisiana with the ambulance, Night Watch. And the one paramedic from that got another show where they followed the fire emergency personnel around. Like, one was in New Jersey, one was in Louisiana, there was one in Texas, 2 were in California. I don't know. It's one of those live EMS shows where they were showing you like as the calls happen. There was one call with a dude running around in the park with his underwear screaming with like 4 cops trying to chase him. Like, that's delirium. Okay. That's excited delirium. All right. He wasn't on anything. He wasn't intoxicated, and his drug screen came back negative. Like, he was just having a bad day mentally. Okay. So just be aware of that. All right. Use law enforcement if you have to. Okay. Other causes of AMS: intoxication, psychological disorder, sepsis. All right. We try not to RMA anybody who's altered, right? If they're altered, they are not in the right frame of mind to make a decision about their health treatment, okay? And that comes into implied consent, where we can kind of sort of force them to go to the hospital, right? But how aggressive do you want to be with that drunk person who's acting ignorant, who you know like is well over intoxicated? All right. So you and the officers have to make that decision on how involved you're going to get. All right. Same person, you get called for someone who they're like, she's suicidal, right? She told me she wants to blah, blah, blah. You get there, she's perfect sunshine and rainbow. She's happy. She's playing the game. She's like, no, I'm not going anywhere. She's like, I don't know what they're talking about. I didn't say that. They just think that because I've done it in the past, right? And you're like, oh, right. So now you got to weigh your decisions. Okay. Did she really say it? Did she not say it? Right. Most oftentimes we're going to err on the side of caution. The police will absolutely, they'll make her go, especially if they have a history, him or her. All right. Doesn't always have to be a girl. Just the one I was thinking of was, right. And that's what happened. Like she said she was fine and she was acting fine. She didn't seem altered. Right. But the cops made her go because her friend said that she wanted to harm herself. And we were like, well, if you're filling out the paperwork, we'll give her the ride. The cops can 941. It's called the 941 in the state of New York. The cops can deem at any time that you are not mentally stable, and they have to fill out paperwork, and they can take your rights away, and they can send you to be evaluated at the hospital. But it's a lot of paperwork for them. So if they're doing it, they know that something's wrong. They're not just doing it to do it. Yeah. Okay. Yeah. Did you have a previous history of? Okay. Yeah. Something led those cops to believe. Oh, they can absolutely, and they're going to err on the side of caution every time, because if we show up and someone says that they're going to kill themselves, and we're like, no, I think you're just calling it because you want to be a dick, and then they go and actually kill themselves, like, we're the ones in trouble, not the person that called it in, right? And it's ultimately on the cops, because they're the ones that usually have to get involved, especially if they don't want to go to the hospital. All right, so they're going to err on that side of caution every time. They're not taking the chance, right? You go in, and it's not mandatory. It used to be a mandatory 3 days. I don't even think they do that anymore. When, like, if the cops used to fill out paperwork on you, you used to have to stay in the hospital 3 days. And you had to go in front of a judge and prove that you were good to go or you had more treatment. I think nowadays, like, as long as, you know, that those two physicians at the hospital sign off. Yeah, usually yeah. So they've changed it a little bit. It used to be mandatory 3 days, which made people pretty upset. Okay, so now we're back to our wonderful scene size up / assessments. Okay, so scene safety, basically, right? We're going to worry about us and our patients, right? We're going to do everything that we've been doing for everything else. All right, we're going to, if they had a seizure from a standing height, all right, they got a crack on their head, they got a black eye, if they got a bruise somewhere, we're going to put C-spine on them because we don't know. All right, we don't want them to be injured any further than they already are. Okay, this is where you got to put your EMS detective hat on. Okay, you got to look at everything. All right, you got to look at the whole picture. You got to look at the scene. Are things knocked over? Are things disheveled? Is the table broken? Right, because I've had people seize and fall right through the glass coffee tables. All right, so you got to look for everything. Okay, again, right, like the first one says, evaluate the environment for trauma. Okay, try to find medications if they're by themselves. All right, because a lot of times, sometimes you'll be talking, right? The daughter will be talking to mom on the phone. All of a sudden, mom stops talking, right? Doesn't answer the phone. Phone hangs up, calls back, right? Daughter's like, calls 911, says, go check on my mom, please. And mom's passed out on the floor for whatever reason, right? So they may be the only ones there, and you may have to figure out what's going on. right? Is there evidence of that seizure? Like I said, is there stuff on the floor? Is there disheveled stuff everywhere? Okay. And if there's family there, when, you know, everyone, we all need to know the last known well time. All right. Any sort of altered mental status, they always want to know when the last well time was. All right. How long are we dealing with? Okay. As always, we're going to treat life-threatening concerns first. Stop the bleeds, right? Do your rapid exam, especially if you think trauma was involved. All right. Put your super sleuth hat on, gather whatever information you can from the scene, take pictures if you feel that you need to take pictures. Okay. Just remember that in those pictures, no identifying information can be in the picture. All right. So if you're taking a picture of a car, you can't get the license plate. All right. Don't take pictures of their health insurance information or their paperwork so that you have it so you can read it later. Write it down on your glove, throw it away. All right. Obviously, we don't post any pictures online. Thanks to HIPAA, you guys should know this stuff. All right. Again, note where the body was and where they were, especially if you think it's going to end up being a crime scene. Okay. Because we might have to leave, and you might have to do a deposition with the cops and explain to them exactly what you found. All right. So that first general impression of your scene is going to let you know what's going on. Okay. Again, you should be able to notice a seizure. All right. You'll see that drooling. They may be incontinent. You'll see that other stuff that we talked about. All right. Determine their level of alertness. Right. That's going to tell us their severity. All right. Then we move on to the ABCs. Okay. Suction if you have to suction. All right. Position the patient on the side to prevent aspiration. All right. Do that quick. Check to make sure there's nothing in there, that it's not a simple choking. All right. So anybody with AMS, all right, should have oxygen. Again, doesn't necessarily have to be high flow. Just make sure they're above that 94%. All right. So if it only takes 2 liters nasal to make it work. What are the little hand things? Were they warmers? Oh, that's cool. If we have to ventilate for the patient, ventilate for the patient. Okay. Same as we always do. All right. 10 to 12 breaths per minute, 1 every 5 to 6 seconds over a full second. All right. We're not going to hyperventilate them. All right. Because we know what happens. You can decrease their cardiac output. You can increase their gastrointestinal pressure and make them vomit. Right. We don't want to do any of that. Okay. And if there is too much ICP because of a head injury, right, you may cause further brain problems. Right. We talked about that kind of stuff. We're going to go to your C's. We're going to check for pulses. We're going to do CPR if we have to. We're going to use the AED if we need to. Right. This we want to know. Well, we always want to know, but we especially want to know what the pulse is. Right. Is it fast, slow, strong, weak, bounding, thready? Okay. What's going on? Right. And like I said, we're going to look at that types of bleeding. All right. And then we're going to figure out our transport decisions. All right. Most likely all your unresponsive or lower responsive patients are going to be immediate transports. Right. If they're actively stroking, right, we only have that certain amount of time. So they got to go. Okay. History, if we have a chance, right? If there's people around, again, we're going to investigate what kind of history do they have? What kind of medications do they have? Right? Is it a stroke? Is it a seizure? Is it a diabetic emergency? Okay. If they're responsive, clearly we're going to talk to them first, no matter what happens. All right. If your patient's alert and oriented, ask them. All right. And then if family wants to say something different, okay, family wants to say something different happened. All right. Try to judge who's more calm, who's more rational. All right. Whose story sounds more viable. You know, I'm not going to get into family dynamics, but unfortunately, if she has a history of mental illness, they're not even going to question it. Okay. Sample, again, you get as much as you can. All right. We're not sitting around waiting all day. Okay. The last known well time is the most important thing the doctor's going to ask you. All right. They want to know how long the patient's been down, how long they've been altered. They want to know where they're at time management wise so that they know what interventions they can still do. All right. Take all the medications with you if you want, or if you have someone that can write them down real fast. All right. Before you leave, but don't wait around. All right. Find out if what their history is. Find out why they called this time. Right. Was the seizure different? Did it last longer? Was it a different type of seizure? Did they have multiple seizures? Right. Is it a stroke? Like what happened? All right. And if they don't have serious conditions and they're in a serious state, then something obviously happened, right? Something new happened. It's a new onset. All right. So now that we're in the truck and we're driving super fast down the road, all right, we're going to do that full body assessment. Okay. We're still going to do a full body, but we're going to pay more attention to what's involved. So we're going to keep doing neuro checks, right? We're going to do that Cincinnati stroke scale repeatedly. Did we go over this stroke scale? No. Okay. So Cincinnati stroke scale has 3 components to it nowadays. There's other ones that you can use that are out there. The doctors, I don't know if they use the NIMS scale or the other one, but they have pictures. There's a whole book. It's like 7 pages they go through. All right, for us, it's pronator arm drift, right? So they're going to close their eyes. You're going to have them hold out their arms with their palms up, and can they hold them steady? Right? If one starts drifting or one immediately flops, and you'll know. I mean, like you're going to go and you're going to hold up their arms and help them, right? And you're going to hold them. And when I let go, you hold on. You're going to know this arm's already flaccid, right? By like if you have to fully lift it up and hold it there, you're going to know. Okay. So you have them smile, right? If they have that one-sided facial droop, okay, or if the smile looks all crooked, or if their like skin is like this and you can see the bottom of their eyeball, right? If that whole, all the muscle tone is gone on their face, right? Sometimes you can just walk right in and be like, yep, nope, we're gone. Right? You don't even need to have them smile because you can just see the whole side of the face like falling off. All right, it's just drooping that hard. And the other one is talking. All right, so there's 2 phrases. Okay, they used to, for us, it used to be you can't teach an old dog new tricks. All right, if they can say that relatively good, they're okay. The new medics, they keep coming up to me and they tell me like, you know, when I hear them on scene, they'll ask the patient, was Mickey Mouse a cat or a dog? Okay. Most people will either get stumped trying to figure out a cat or a dog and, you know, not say mouse, but they'll ask them, is Mickey Mouse a cat or a dog? All right. Any sort of extemporaneous thinking, okay, they probably won't be able to do if they're having a stroke. All right. So you can come up with your own questions. You can look at the NIMS and adopt certain ones. You know, after seeing doctors do some, if those 3 kind of look okay, or I'm still unsure, like I'll go into some of the other tests, have them stick out their tongue. I'll do the whole touch your finger to your nose trick. Okay. If they can't do it, like put your finger to your nose. Right. Or you can do the nystagmus check, follow my pen. Right. If they don't follow it at all, or if it clicks, right, there's something going on. Okay. So there's other tests we can do. All right. Then we do our vitals, obviously 5 or 15 minutes. Okay. Always check pupils, especially in the stroke. All right. One pupil may be the size of a dinner plate. One pupil may be normal. All right. Whichever size is dilated, the other side will be the one hemorrhaging. Right. Usually we'll only see it in the bleed. Okay. But if you do see, some people have, is it diplopia or anaplopia, where they're born with the 2 different size pupils. I think diplopia is it's not diplopia. I'll look during the first break. All right, but sometimes people are born with 2 different size pupils, and they'll usually be like, you can ask, like if you see one's off, then the other one, and right, you can ask, and they usually know. All right, so again, anything that falls in this category, we're doing blood sugars. All right, my mantra for blood sugar is any altered mental status, for any unknown reason gets a blood sugar, right? We can actually simplify that now to any altered mental status gets a blood sugar. All right. And as far as the company goes, anybody with any generalized weakness, we also do blood sugars for now. Okay. Sometimes it's that simple. Just about every patient nowadays gets a blood sugar. Yeah. Yeah. Just like almost every patient now, thanks to the state, gets a 12 lead. Because if you have abdominal pain, nausea, vomiting, any type of sweating, like they wanted us to do 12 leads. So almost every patient's ALS now. Usually the vital signs in a postictal period will be around normal. Okay. They're not low, they're not high. Sometimes if you get it, if you're doing it with the auto cuff, all right, sometimes their blood pressure may go way up if it'll even take it with all the movement during a seizure. But usually it should come back down to normal. Okay. These are the ones that we've been doing. Like I said, I told you about the Cincinnati one. All right, there's the Los Angeles version, and there's the new 3-item lag scale, stroke severity. Okay, looks at your AVPU, your pronator function, and your gaze. All right, so when I do them, I kind of merge all of them into like one test, and we go from there. So this is their new mnemonic. All right, you'll see them all over the hospital, the fast stroke scales. All right, facial droop, arm drift, speech, time. All right, again, that's what the Cincinnati does. You look at their face, do the pronator drift, ask them to talk. All right, and the last one is last known well time. Always, always with altered mental status, ask the last known well time. All right, that's the biggest one. That's the most important. Okay, so the Cincinnati, all right, I talked about, we do the facial droop, show your teeth, smile, the arm drift. Okay, they're saying is the sky is blue in Cincinnati. All right, we're literally only looking for slurred speech, right? Or inappropriate speech, like they can't form the words or they can't talk at all. All right, we're not asking them for an exact, well, we kind of are asking for an exact replica of the sentence, but okay, so if you can find a statement of your own that you like to ask, right? It doesn't really matter. All right, we just want to make sure they're not slurring their words. Okay, so the Los Angeles one gets a little bit more involved. All right, they want to know the age. Okay, they want to know the history. All right, they want to know if they've had symptoms within the last 24 hours. All right, what is their baseline? Are they wheelchair bound or are they bedridden? Okay, this way we know their motor function status before we even check. All right, what's their blood glucose? Again, is it hypoglycemic? Okay, is there any asymmetry involved? Right? And then, okay, so if all of the criteria from 1 through 6 are marked yes, it's 97% chance they found that they're having a stroke. Okay. I don't know why the wheelchair or bedridden has anything to do with it. I honestly can't explain to you why that's the criteria they use. All right. I don't use this one. I don't understand it, to be perfectly honest. Okay. And this is the 3-item lag one. So they do the facial smile grimace. You can have them grip your fingers. All right. You're looking for weakness in one side or the other. Okay. You can do the whole gas pedal, push forward, pull back if you're looking at their legs. All right. And again, the pronator drift. Do you have any idea why they choose those? Like these are so weird, right? Why does a wheelchair or bedridden have anything? How is that going to help you determine a stroke? Right, but this is not, right? If it was, then I don't understand because we're thinking of a DVT that popped loose and got somewhere, right? But this is not. So this is people who walk, right? So how is that, right? They're not wheelchair bound or bedridden for a baseline. Okay, so these are people who are like us who walk around on a normal basis. All right, if they were in a wheelchair or bedridden, then I would suspect a DVT, and I would be okay with that. But I don't understand, like, right, how this 6 groups grouped together, obvious, other than the obvious asymmetry, okay, in any of these. But this is the Cincinnati one anyway, so like this is your stroke scale. Like, I don't understand what the first 5 have to do, right? Number 6 should prove it for you. But yeah, so I don't know, but they want you to know. Oh, this is the other one, the gaze. This is the lag one. Okay, so they have the level of consciousness, the arm drift, and the gaze. This is the one where you push the finger back and forth. All right, do they follow? Is it fixed? Do they stare? Is their pupils clicking? Okay. They have numbers assigned to them. All right, anything greater than 4 indicates a stroke is likely. All right, so you guys I like the Cincinnati one. I'll throw the Cincinnati one in with a little bit of this one. I'll do the grip strength. All right, I'll have them stick their tongue out, stuff like that. Again, we're gonna do GCS. We do them for everybody. Okay, so there's no reason not to do them with alternate mental. All right, you can look over this. I know we went over this during trauma. Okay, so you guys should know your GCS scores. All right, you're gonna have to memorize those. All right, and then we do our reassessments, right? We're gonna do our neuro checks because they may be having a TIA. All right, so now we wanna know the time of the symptoms, how long they lasted, when they resolved. They fully resolved, did they get partial resolvement? All right, what happened? Okay, what did we do? Right, what do we have to do? What's their baseline? All right, where are they at? And these are ones we're gonna call early. All right, these aren't your 5-minute, we're 5-minute out calls. These are your, I'm leaving with a stroke patient, we're 15, right? Because it's a whole team. They have to clear the CAT scan. All right, they have to make sure X-ray and radiology and all them are ready. They got to get the orders ready. Okay, it's a big hole. Usually you come in the door, especially if it's a stroke, walk right into the CAT scan. They'll do the scan and then they'll either tell you to go to a room or right upstairs if it's that bad, and they can clear out radiology, interventional radiology. I've had a couple where they've gone right upstairs. There was nobody in there. The team was called, team was on site. They were already there from a previous call. Okay, that's why we call the stroke alert and call it early as you need to. Okay. And again, they want that last known well time, why you think it's a stroke. All right. And when you're showing up so they can get all the proper teams ready. Okay. And then documentation. All right. Again, certain ones are like the mimics, right? Certain conditions are easier to notice. Okay. It may look like a stroke to you and you may call the stroke, okay, but it may not be because we can't see those other signs or symptoms, right? So that's why we're going to bring them in. Usually we go right to the CT scan. Okay, they can give them the blood clots. Oh, the hell's that called? I haven't done a stroke in so long, I forget what it's called. Thrombolytics. They give them thrombolytic therapy. Okay, there's a special one. I can't remember the name of it. However, if you've had a previous stroke or blood clot, then you're no longer viable, okay, for that kind of therapy. All right. Again, based on the amount of time, treatments are available. Okay. They are very time specific, but they work well. All right. So we know that TIAs are going to be the same. Okay. We're going to transport it the same. We're going to act the same. All right. Because we don't know if that's going to get lodged somewhere else. We don't know if it is a clot. All right. We have no idea what it was. All right. But they had some sort of neurologic event. It's not something that we should just let them go. Okay. We're going to keep them in a safe, secure position. All right. They're paralyzed. They can flop around. All right. Usually I will wrap in a blanket pretty well. All right. You're going to put the seatbelt over that arm or that leg so it doesn't fall off the stretcher and keep falling or keep hitting you or keep messing up. what you're trying to do. Okay. Keep talking to them. All right. This third bullet point, they may not even be unconscious. Their eyes might be open. They may be ataxic. They may hear everything that's going on around them. Okay. They may not be able to communicate to you. All right. So keep talking to them. All right. Let them know what you're doing. Let them know what's going on. Let them know what you think is happening. All right. Don't talk about going to the bar later or what you're doing after the call. Right. Because they may hear that. All right. And then obviously we've beat time into a death at this point. All right. Seizure patients. Right. What are we going to do? We're going to do our standard O2 therapy, position of comfort, and keep them protected, right? Maintain the airway, suction if we have to, okay? And then if you think it's some sort of traumatic event, or they hit their head or they fell, at least from a standing position, right? Put a collar on, okay? Don't take that chance of causing further spinal injuries. All right? And then call ALS because they may need some Versed. Headaches, we don't do a gosh darn thing. All right, we do have Tylenol now. I still refuse to give you oral Tylenol for a headache. Okay. Like I said, the only headache you should worry about is that thunderclap headache, and then it's a stroke, and we're gonna treat them under the stroke protocol, right? We're not gonna worry so much about a headache. All right. Again, migraines, I will kind of help because migraines are kind of a pain in the butt. Again, there's nothing I can do. Worst thing, I mean, the best thing we can do is turn the lights out inside the truck. All right, give them that dark, kind of quiet space. All right, the best we can. Just make sure it's really a migraine. Okay, and then strokes. Again, we've talked about O2 therapy, 94% or better, right? Rapid transport. You may have to put an airway in. Okay, I've had stroke patients who will literally just keep vomiting. All right, and it is the most nasty smelling vomit I've ever smelt in my entire life. It like makes me want to vomit. It's just, I don't understand why stroke vomit is different. Okay, but stroke vomit is different than like food poisoning vomit. It just is. I can't explain it to you, Joe. I can't. I know you're looking at me like you want an explanation. In my limited experience, okay, stroke vomit has a very particular, like acrid, acidy smell. You know, I haven't switched it around a wine glass and kind of given it the sniff test, but you know, it might have fruity notes to it. Versus just like plain normal regular vomit that, you know, kind of doesn't have like a smell. It's like a foul, rancid, like it goes bad in your stomach. Like it's just rancid, like raw meat that went bad. Okay. Again, protect paralytic, protect the extremities, keep them informed, right? Time is brain, kind of like time is heart. All right. Stroke centers everywhere around here is a stroke center. Northern's a stroke center, Mid Hudson, Vassar. So no matter where you're at, okay, they're all stroke centers. They're all capable. All right. Vassar's a better one. So is Mid Hudson because they can do interventional radiology. Here they can do the CT and they can be like, hey, he's got a bleed. He's going to Vassar. All right. Or he's going to go to Albany, one or the other. But they are a stroke center. You can drop them off. They can start the TPA. See, now that I talk more about it, I can remember things. Right. TPA is just the thrombolytics. They can start that medication if they require it or if they're allowed to have it. Right. And then they can transport them on the TPA up to somewhere who can do interventional radiology if they have to. Seizures, your best bet is to move them in that postictal state when they're not seizing, right? Wait for that seizure to stop. Get them up off the ground and move them onto the stretcher or the reeds. Okay, try to do all of that work in that postictal place. They can't fight you, all right? They're calm, they're still, they're not moving, all right? Treat your ABCs, give them oxygen, all right? I can promise you if they have another seizure, nasal cannula is gonna fly right off their face. All right, so use a non-breather if you can, but again, just be careful because you might have to move it to suction. All right. Trauma, spinal immobilization, right? Don't restrain them if they're having seizures. Okay. Leave the buckles kind of loose, but not super loose. You don't want them tight and tied down. All right. And then, like I said before, if they've had a history of seizures, you don't have to transport everyone. Okay. We should advocate that every seizure patient should be seen at the hospital, right? Because it could be a different seizure, could be a different reason. Why isn't your medication working? Why did the seizure break through? Okay. May have to call med control. All right, but ultimately that seizure patient has the final decision. All right. Altered mental status, we've talked about. All right. Oh, and that's abdominal. All right, let's take a break. Okay, we'll get into abdominal when we're done. So take 15 minutes and then come back. Anybody have any questions on the last part of neurology before we go?
Yes, one.
Hold on, Carolina. Joe's asking
Okay.
a quick question about GCS. Hold on. All I heard was our kids screaming. The GCS? Because that numerical value is what you can tell the hospital, right? When you're doing your brief radio report or your nurse report, you're gonna be like, patient had a stroke or a seizure, patient's current GCS is 11. Okay. Not over the radio, like when you give your nursing report, you will, but that's your brief 30-second over the radio, down and dirty, like coming in, they're altered, GCS of 11, vitals are, I'll see you in 10 minutes. Okay. Then when they get there, the nurse will be like, well, why is their GCS 11? Take a look. You'll figure it out, right? Like you said, like your presentation will tell you, but no, you'll tell them when you get to the hospital. All right. So it's one of those things that doctors like to know ahead of time before you come in. Carolina, what was your question?
Would Bell's palsy be considered a neurological emergency since it has that, same facial drooping of the face? Because I've seen it before, just wondering.
So Bell's palsy is a diagnosed condition. They're usually on some sort of regimen for it. Hopefully somebody is there that can tell you, or they can tell you they have a history of it. And if you do see the droopage, again, I wouldn't totally recommend saying that, yes, it's just Bell's palsy, because it could be something else, but just know that it might be Bell's palsy attributing to that. Okay. But that they may still be having other neurologic issues. Okay. That's kind of one of those hard ones because it does mimic a stroke and it's a long-term mimic and there's nothing we can really do about it. All right. So I would advocate more, especially if family is saying that they're more off or there's something going on or they're not quite right, that I would advocate for transport at that point.
Okay.
Okay. All right. We're going to keep going. Okay. So this is basically going to be a small review of our last trauma test, right? Because I had you guys label the solid and hollow organs, and I'll just make this generalized statement now. Please do not put 42 labels on the image. All right. In order for the computer to get it to say that you were right, you have to put it in the exact same spot that I put it. All right. Put the little crosshairs on the organ anywhere, and I will give you credit for it. All right. I have to go back in and manually grade them. I had some people who literally labeled like around the large intestine, like the whole, put like 15. They're like, you have extra. No, there's not extra. All right. There were 3, there were 4. Okay. They each went somewhere. There was no extra labels on anything, or even the skull. There was 9 labels. They all had a place. All right. There was no extra labels. I won't do that to you. If I give you a label, they all go in a certain spot. What?
There were also, I just have a question. There were also like lines that
Yeah,
were
so the
like
lines, that
drawn
was the
out. So if
best
you put it at the
diagram.
end of the line,
No, because the line wasn't necessarily the right answer, which confused some people, and I gave people credit
Yeah,
for
no, that
because
confused me a lot.
I,
Yeah,
I
okay.
noticed some people were putting them in the wrong spots, but the lines was the best picture I could get, and I couldn't go in and just erase the lines because that would look weird. So I probably should have put something in the description, and that's my fault, and I will, which is why I gave people credit if you were close. All right. If you put it at the end of a line and said this is what it was, I was like, I can see why they did it. Okay. That's why I go in and manually grade it, because it gives me the option. All right. So I'm going to try to find more pictures like the skull that have no lines where they're color coded. And I can just be like, you know, as long as you hit the right color in the colored area, I'll call it good. All right. So where is, there we go. All right. So we know our hollow organs. The only additional one we're going to add this time is the bladder. Okay. We didn't have that in our trauma section. All right. I couldn't find one that had a see-through picture of the bladder because it's behind the intestines, right? So I couldn't actually tell me where to put the bladder was. All right. And if I put a whole section up that was just the bladder and stuff, it would have been way too easy. Or it might have confused some people. Who knows? It might have labeled a kidney a spleen. But all right. So the only thing we're worried about, and like I said in trauma, it's the same thing. Okay. Any breach of these hollow organs cause the contents to leak out and can cause a septic environment. All right. So again, more anatomy. All right. We're going to add the ovaries in. We're going to add the kidneys in this time. Okay. We'll add the ureters, the fallopian tubes, the uterus. All right. And the bladder. Okay. I will not be using these diagrams because they're kind of confusing, but I will find better ones. All right. You'll probably see them again. Okay. So what does the GI tract do? Right. Starting at the stomach, going all the way down to the rectum. What is the GI tract used for? Right. Digestion, right? Processes the food. All right. Starts in the mouth. There are certain proteins in your saliva that start to break food down a little bit. Okay. Food is swallowed. Who knows what the name of the term is that gets the food to the stomach from the mouth? What is that rhythmic motion of the esophagus called? Huh? Swallowing. Yep. That's the everyday term for it. What's the fancy mark term? Peristalsis. Okay. Peristalsis is the rhythmic contractions, okay, of the it's almost like a snake wriggling across the ground, right? Your esophagus squeezes and squeezes again. It's almost like trying to get the last bit of toothpaste out of the tube. Think of it that way, right? Okay. So you don't just swallow it and goes clunk and drops right down, right? It holds it. It's very nice, slowly brings it down. Okay. Otherwise, you kind of feel it. All right. Kind of like when you drink too fast, you just feel it kind of like you almost sometimes you can feel it go the whole length. All right. Stomach is where most of the digestion takes place. All right. We all know we have our acids. Okay. Bile helps with fats. Okay. So the liver will secrete bile to hold it in the gallbladder. All right. Which is why when you're having gallbladder issues and you continue to eat fried chicken, hamburgers, greasy, fatty foods, you have a problem because you're not getting that bile in, and then your stomach has no clue what to do with the fats, right? Because your stomach's like, I need help. I don't really deal with this. I don't have the proper enzymes. Someone help me out, right? So if you're having gallbladder issues, right, because there's no bile being stored, okay, then there's no place to go. All right. The liver also filters out toxic substances, right? It's our first filter, mostly concerned with blood products. All right. It filters out the broken red blood cells, hemoglobin, white blood cells, all that good stuff. And it also works with the Krebs cycle, creates our glucose, okay, and stores all that extra sugar that we eat. All right. So small intestine has a couple portions to it, right? Your first portion is the duodenum, all right, where all those digestive juices from the pancreas, the liver, all right, the pancreas drops amylase, bicarbonate, and insulin. They're all specific proteins that break down certain things. You guys don't need to know. All right, there was that one stupid quiz question where even I read it wrong. All right, and the answer was pancreatic juices. That's the pancreatic juice. All right, it's that mixture of proteins up there. The most important part of the pancreas is the insulin. Okay, it's what you guys really need to focus on. The next part of the intestine is the jejunum. All right, it passes, oh, I forget what the actual sphincter is called, but there's a valve between the duodenum and the jejunum. I know the pyloric valve is between the stomach and the duodenum. And there's another one down farther. Okay, I can't remember the name of that one, but it passes through the next section. Okay, the jejunum is the workhorse. All right, that's the one that does most of the digestion, the reabsorption. All right. Let me see if it says over here in the notes what it's called. Nope. All right, then it goes down into the ileum. All right, because it's in that region, in the ileum region, iliac region down here. Okay, this is your last chance. All right, this is where anything that wasn't absorbed in the jejunum gets reabsorbed here for whatever reason. Okay, this is also going to absorb extra bile. All right, so that it can return to the liver. Okay, it takes that B12 vitamins that we're supposed to be eating, right? All our good vitamins and minerals. Okay, to remake certain nerve cells and red blood cells, right? So all that stuff gets reabsorbed and passed back to the liver, all right, through the bloodstream. So if you have a, vitamin deficiency or whatever, you may have ileum problems, all right? That's where most ostomies are usually placed, somewhere in the ileum. All right, we can take a look at ostomies later if you want to. I might actually have them in here. Okay, goes to your colon. This is everything that's not broken down, right? So corn, all right, usually doesn't break down, right? If you ever notice you have corn the night before, most times you often kernels are still in your fecal matter in the other day. The only thing I know that breaks it down is some sort of acid, lemon juice or lime juice. If you squirt lemon or lime juice on your corn, it will actually start breaking down the outside kernel, and then you can actually digest it and you will not have corn in your stool. All right, not everyone likes a little acidic corn every now and then. However, if you would actually like the nutritional information from the corn, right, because we don't really digest it, it just kind of passes through us. There's no nutritional value in corn because we don't break it down. There is, but we don't get it, okay, because it literally passes right through us. So if you want that nutritional value from the corn, a little bit of lemon or lime juice, some sort of acid to start breaking down that external kernel, okay. I don't know why it works, Joe. I know you're looking at me like that's the dumbest thing I've ever heard, but I can tell you when I make corn salsa and I add some lime juice and lemon juice to my corn, I do not find any corn in my stool the next day. If I eat a plain old corn on the cob with some butter and salt, it is the Rocky Mountains the next day. All right, it comes out a little chunky. I don't know. I know I've actually looked it up. It is a thing. Like if you add acid to corn, it will start breaking it down. Your body will get the nutrients from it. Okay, it's just, it happens. Again, peristalsis also works in the intestines. Okay, colon is where we reabsorb the last of the water. All right, so when you have diarrhea, it is moving basically from your ileum straight through. All right, the colon is kind of almost quivering, like fibrillating. All right, it is not staying in the colon long enough to reabsorb all that water. It's why you get dehydrated. It's why you have to take fluids. Okay, and this is where that stool is formed. All right, and this is where, when you have people who have abdominal problems, you have to go check the toilet and look to see if there's fancy colors inside, what it looks like, what consistency is it. All right, these things actually matter and can help. All right, the spleen we talked about. All right, it's more of the lymphatic system. Okay, it again helps the liver in filtering blood and developing red blood cells. All right, does produce some antibodies. Okay, we're not going to go into the lymphatic system. It's like one of those peripheral systems that do a lot of things. That kind of, it's like the dark workhorse of the body that no one ever talks about. Okay. So just, the spleen, we want to know where it is, because if it ruptures, again, it's a problem. All right. And in most traumatic instances, all right, the spleen is what everyone forgets about. Okay. Then we have the male reproductive system. Okay. We have the testicles. All right. Testicular torsion is a thing. It's not fun. Okay. Testicular torsion is, for whatever reason, the ones that are not up there, the actual tubes get twisted inside the scrotum. Okay. And it literally looks like a yo-yo all knotted up in there. Okay. Usually happens if you run down the stairs too fast in young kids. All right. It's a thing, Joe. It happens. It's extremely painful. All right. So just know testicular torsion is a possibility. All right. There's different parts. We'll talk about them. The prostate gland. Okay. And obviously the penis. Obviously, it's the most obvious difference in the genitalia, right? It is the, I don't want to say the elephant in the room, but sometimes, depending on the person. Okay. Insert bad jokes here. All right. Female reproductive system, we have the ovaries. All right. There's a lot of PCOS out there. Okay. A lot of fibroids, a lot of stuff that happens in the ovaries that causes a severe amount of pain for these poor young ladies. All right. It is a thing. Okay. Sometimes that will give them pain management. It's usually the only thing that helps. All right. Especially if they have a history of it. All right. Fallopian tubes can do the same thing. All right. They can twist up and do some weird things. All right. The uterus, again, depending on the age. All right. There can be fibroids. There can be bleeding. Be a whole bunch of things going on. All right. That cervix, okay, is the actual opening to the birth canal. All right. The vagina is the birth canal, but the cervix, all right, stays closed for the uterus. All right. Except when the pregnancy cycle, they have that window where the cervix lifts up a little bit. All right. So that sperm can get through and create an infant. Okay. And then it closes itself off again. All right. So our urinary system, right, controls discharge of fluids, right, happens in the kidneys. We have 2 of them. We can live with 1, right? You can donate one can get taken out. Okay. Sometimes they don't work. We go to dialysis. All right. They're in the back. So flank pain, usually one side or the other. Any type of searing pain that people say moves, like from my back down into my pelvis or my pelvic region, right? What are we worried about? Kidney stones. Okay. They regulate your pH and your blood pressures. All right. They're the other filter. Okay. They filter out toxins. All right. And kidneys are highly vascular. All right. Highly vascular. They have a lot of blood in them. All right. So people get kidneys or their kidneys rupture. All right. There's a chance they could bleed pretty seriously. All right. We know the ureters, the 2 tubes that come out of the kidneys into the bladder, right? The bladder is located basically right in the middle of the pelvis. Okay. In the women, it's a little bit above the uterus. All right. It goes through the urethra. And on average, 2 liters of urine a day is normal. All right. The color of your urine is your hydration level. Okay. The clearer it is, the better. The darker it is, the worse you are. All right. There's usually a smell involved with it. Usually ammonia. All right. So this is the male urinary system. Shows you the kidney, the ureters, the bladder. All right. The prostate gland sits just under the bladder and wraps around the urethra. It is used in producing the seminal fluid. Okay. It's also used for like lubrication, things of that nature. Since we don't have 2 different sets of plumbing, right? Men only have 1. Okay. We don't have 2 different Joe, you look confused. Women do not urinate through their vagina. They have a separate opening. They have two sets of things. Huh? No. I mean, we urinate and we reproduce through the same opening. Women do not. Okay. We have one set of plumbing. They technically have two. All right, if you want to call it that. I mean, technically it's one set of plumbing and a birth canal, but I make it two different sets so that people understand it. Okay. Obviously, the urethra follows through the whole penis and comes out through the opening. Right. So we talked about this before. I don't know why I don't have a picture of the female one up there. It must have gotten taken out somewhere. We can do the female anatomy if you guys need to. All right, or we can do whatever you want. All right. The abdominal cavity is lined by the peritoneum. All right, that's that outer or parietal. Okay, we still have a parietal and a visceral. There's two versions. Okay, so the parietal peritoneum lines the walls. All right, there's a visceral peritoneum that covers all the organs and they attach together. All right, to attach the two peritoneums attached together to keep everything in place. All right, so when something ruptures and falls in between all of that space, we call it peritonitis. All right, and that is an inflammation of one of the two peritoneal layers. All right, anything acute is sudden onset. All right, so these are not chronic people who have abdominal issues, right? Any kind of sudden onset chronic abdominal pain. Okay, we use the terms acute. All right, and it's obviously usually severe. All right, we talked about this a little bit. Peritonitis, basically it's just inflammation. All right, inflammation of the peritoneum. Okay, it can cause ileus. All right, ileus is a paralysis of your muscular contractions within your abdomen. All right, so who can tell me why that's not good? Huh? All right, so peritonitis is an inflammation of your peritoneum, okay? It can end up causing what we call ileus, which causes paralysis of all of the muscular contractions within your abdomen. So why is that not good? Right, well, it's gonna stop your digestion. It's gonna stop the movement of waste products, right? What else is there? It could affect the diaphragm, right? Okay, again, you might retain gas and or fecal matter, okay, which is going to cause distension, right? Your stomach's going to blow up like a balloon, okay? And then most oftentimes it comes back the other way, right? Because the bottom half is blocked. So everything's got to come out the top half. All right. I mean, this is the severe end of it. You should hopefully never see that part. If they get to that part, then they waited way too long. All right. Mark, you look confused. You're looking through the book. Did I miss something? Okay. Yes. Huh? What?
There was a question on the quiz related to the peritoneum. Asked which of these organs are outside of it, but it didn't include the kidney. Do you remember what organ is outside of it other than the kidney?
What organ is out?
Something like that, yeah. Pancreas is outside of that? It's like a retroperitoneal. If I'm remembering the flexion rate, it was one where it was, what else?
Stand by, people. We're going to the quiz for a minute. I mean, we can go over the quizzes. We'll go back to it because I only got 20 slides left. So we'll be done this by 8:30. We can spend the last half hour going over the quiz. We'll go over the quiz at the end. We'll go over it. We'll take a look. So I don't have to like get out of this, try to go into it, share the whole Zoom thing. If it wasn't Zoom, I would do it right now. Okay. Diverticulitis. All right. So inside of your intestines. All right. It's a, well, there are pockets. All right. I'm going to draw on the board. You guys aren't going to see it. I'm sorry. We'll do it when you get back if you want. All right. So if that's your intestine. All right. these are their little villi. Okay, they kind of look like a mountain range, microscopic mountains along the intestinal wall. Okay, what happens is that sometimes things get stuck in here. All right, and they get stuck down in here, and what they do is they cause a space, right? And this gets stuck in here, and then this closes on top of it, and like this gets infected. Okay, and that'll cause either inflammation or possible infection. Okay, so if this area gets weak and these spread, right, that's fecal material basically gets in there and just sits. All right, and never gets a chance to come out and kind of just rots on the inside of your intestines. All right. You tell me, what does itis mean? Okay, so itis could be, so diverticulitis could be what? Right, but it could be a single localized event. Okay, what is osis? Okay, right. So now what's diverticulosis? Right, that's someone who has multiple of these and has chronic issues. Okay, instead of getting it solved when it was simple, all right, they let it keep going, or for whatever reason, their intestines are just getting weaker and weaker. Okay, and it's becomes a diagnosed condition versus a one-time flare-up. Okay, so same thing. We have cholecystitis. All right, that's an inflammation of the gallbladder, which can happen for any number of reasons. All right, they may have fevers. They may not have fevers, depending on whether it's an infection, bacterial, gallstones. All right. Huh? Now, jaundice usually occurs with the liver. So if there's liver function and gallbladder function at the same time, you'll see jaundice. But if it's just the gallbladder, it's usually, you won't see that jaundice. Yep. All right. We also have appendicitis. Okay. Doesn't really talk about it, but your appendix can get inflamed for whatever reason. Okay. So abdominal pain. Why are we worried about it? What is it? Which abdominal pain is worse than other abdominal pains, right? How do we know? Why is most abdominal pain should be an ALS call versus a BLS call, right? So we have two different types of nerves, right? So it's mostly nerve pain. Okay, your parietal, peritoneum. Okay, is your pain perception, your touch, your pressure, your heat, your cold sensations that you're burning. All right, all those types of pain indicators. Okay, your visceral is supplied by the autonomic nervous system, again, because it's your organs, right? So we don't control any of that stuff on our own. Okay, so if it is an organ pain, or if there's something wrong with an organ, you're going to feel pain somewhere else. All right, if your liver's hurting, you may not feel it in your liver, you may feel it in your shoulder blade. All right, if something else is hurting, depending on what hurts, all right, there is a referred pain. Okay, so your gallbladder, again, might hurt here, might hurt in here, okay, might hurt in the area of the gallbladder. All right, but you're not actually going to feel it this side, up under, right, your liver. You're not going to feel it in the middle of your abdomen. You're going to feel it somewhere else. All right, most often in the shoulder. Okay, because that's where those nerve synapses are found. All right, ulcers, simple, easiest causes of abdominal pain. All right, for whatever reason, okay, you got too much stomach acid, too much bile, too much this, your pancreas isn't producing enough bicarb, all right, to keep that stomach at a certain pH level. Okay, so that mucus layer inside whatever organ usually happens in the stomach, but you can have them other places. All right, erodes away, and then that acid eats away at the lining of the stomach. Okay, and that's usually when you find up coughing or vomiting some blood, right? You get that iron taste sometimes. Okay, right, there may be some dark blood in your stool. Okay, if you fix the problem, all right, they can heal on their own if you know what the problem is. When I was a kid, I drank entirely too much caffeine, they told me, and that caused me to have an ulcer when I was like 18. Okay, so I stopped drinking. I used to drink like 2 gallons of iced tea a day. And apparently that was my problem. So I stopped and it healed on its own. All right. I can't imagine. I can't believe I don't have one with the amount of coffee I drink. If they want to tell me caffeine did it with my with iced tea, but maybe my stomach's stronger now. Who knows? All right. Gallstones. Again, we talked about like the gallbladder. Okay. The problem with gallstones, sorry, is when they form, they can block off the actual gallbladder duct, right? And so when that gets blocked, all right, all that juice inside backs up, causes pain, possibly can become infected, all right, definitely gets inflamed, all right, and that leads to cholecystitis, all right. And again, usually it's when people have issues eating fatty foods is when they notice this, all right. Pancreatitis, again, is the same thing. Okay, it's an inflammation of your pancreas. All right, for whatever reason, a gallstone can come across and block off the pancreatic duct. Okay, it can cause it. It's very uncommon. All right, alcohol abuse, other diseases are more common. Okay, you're gonna get upper left and right quadrant pain. All right, you'll have nausea, vomiting. You'll get some distension. Again, because there's a buildup of fluids. Okay, so it's gonna start rounding itself out. If it ruptures, all right, we can go into sepsis or possible hemorrhages. All right, so we're going to look for that. It may refer to the back pain too, as well, with the pancreas. All right, the appendix. Okay, you're going to get nausea, vomiting. You may not be able to eat. All right, you may get like anorexic type symptoms. Okay, everything you eat may come back up. All right, then you're not doing it on your own. You may have a fever. Okay, it's going to be very point tender in that area. It's always going to be down here on the right hand side. All right, don't mess around with it. All right, if it ruptures, it's very vascular. All right, it'll cause sepsis. It's not a good thing. All right, GI bleeds. That is going to be more your bread and butter. All right, there's a lot of GI bleeds. Okay, can be anywhere from the stomach all the way down. Okay, depending on how bad it is, what ruptures, where it ruptures. All right. People may have chronic issues. All right. It may be sudden onset new for this person. All right. It's usually like a dull pain. It's usually what we call peri or around the umbilicus or the umbilical cord or your belly button. Okay. It's more of diffuse. Like when you say point to it, they can't. All right. Because they don't know, because it just all generally feels achy. All right. And like, it's not like a tearing, searing. All right. There's no kind of pain like that associated with it. So it's kind of more, it's a little bit harder unless you actually see the bleeding to diagnose, right? Unless you see, like they show you the bowl and they're like, I've been throwing up this, and it's like coffee ground emesis or like bright red chunks, okay, or you know, they go to the bathroom and they left it there because they want you to see how dark red or discolored it is. And I always say to them, thank you, but I don't really need to see it. But they always want you to look because they don't want you to think they're crazy. All right, so just do what's comfortable for you. All right, so esophagitis. All right, this is more along the lines of GERD. All right, or gastroesophageal reflux disease. All right, it's when the acid starts bouncing back up, causes inflammation of the lining of the esophagus. Okay, maybe it gets infected. All right, but you're gonna have difficulty swallowing. You'll definitely have heartburn. All right, nausea, vomiting. You may have sores in the mouth, especially if the acid is coming through and you're vomiting a lot. All right, it's gonna start wreaking havoc on all the soft tissue in your mouth. Esophageal varices are serious, especially in alcoholics. All right, these are small, basically, if you want to consider them aneurysms or blebs within the esophagus that are highly vascular and will bleed very quickly. All right. It's often very hard to eat or drink because it's so painful for the food to pass over them. All right. So you'll see people who are tired, weight loss, anorexic, jaundiced. All right. They may even have some extremity edema. All right. If they rupture and they start throwing up blood, it's going to be a lot of blood. All right. So control the airway the best you can. All right. Just be careful. This one, we don't really talk too much about, but Mallory-Weiss syndrome. Okay. That pyloric or the pyloric junction basically tears open between the junction between the esophagus and the stomach tears open. The other one's at the bottom of the stomach and the duodenum. Sometimes because all that stuff gets pushed up a little bit. Okay. Primarily they should be vomiting. All right. Again, it's obviously surgical. Okay. They got to go in and repair it if the tear is big enough. Okay. So just control the symptoms, get them to the hospital. All right. Gastroenteritis. All right. That's everything. All right. That's your stomach, your intestines. Okay. That's a little bit of all of it is either infected, food poisoning, right? Your fauna is a little bit off. Okay. Everyone's got bacteria in their digestive systems. Sometimes it gets a little crazy. And they have this new thing now where they will do stool transfers, where they will take someone's healthy stool and put it inside of your digestive tract so that their healthy bacteria that is in the stool can now mingle with, oh yeah, no, someone else's. Nope. They will take stool that has healthy bacteria in it and they will implant it so that your bacterial stuff in your intestines will start generating off of that healthy bacteria versus the unhealthy stuff that was in there. Right. So we do have our probiotics, right? Everyone that does the probiotics, okay, we have that ability too. If you are so far beyond that ability, poop transplants, right? Poop transplants.
It's a really good idea. It's just in a little capsule. It's actually a really good idea.
What's a really good idea?
The capsule, the transplants. It's like, I know a lot of people that have been like seriously considering it and like have talked to their friends and it like helped them out a whole ton.
See,
Lucy's
heard
just had that deficiency their whole life.
It's not like just raw poop, like they encapsulate it and it's the bacteria, right? But it's a thing, like it promotes GI health. Okay, there are certain people who thought of it. I don't know who thought of it, right? I'd rather do the probiotic thing and eat my yogurt or take a probiotic vitamin or something before I have to get someone else's excrement put inside my body or someone else's bacteria. Okay. But no, it's a thing. All right. So diverticulitis. All right. My lovely drawing over here of the fecal matter getting stuck between the mountains. Okay. Again, fever, body aches, chills. It ends up becoming an infection more than an inflammation. All right. Starts as inflammation, turns into infection. All right. And then our number one false GI bleed culprit, hemorrhoids. All right. Everyone goes to wipe, see some blood on the toilet paper. It's bright red. They freak out. All right. It's probably just a hemorrhoid. Okay. The blood vessels around the rectum get inflamed. They get engorged. All right. People who stand around on their feet all the time tend to get them. All right. Again, people who are too sedentary tend to get them. Apparently pushing too hard, okay, straining too hard can also cause hemorrhoids. All right. So like let your body do what it wants to do. All right. If you feel like there's something still there, but it's not coming out, just let it go for the next one. Right. Don't try to strain so hard. Okay, don't try to push things out that don't want to come out right now. Okay, bless you. Cystitis is a bladder infection, also known as UTIs. All right, because the urinary tract usually becomes infected too. All right, comes from up here, goes out, usually the whole system gets infected. All right, requires antibiotics. All right, try to get it before it goes into the kidneys. Okay, you don't want to go on dialysis because your kidneys are shutting down. All right. Usually the urgency and frequency of urination will go up. Okay, there is altered mental status in the UTI. All right, there's also a smell. You can usually smell it. It's nice, very pungent ammonia, sour odor. All right, even if they haven't urinated or urinated on themselves, like you can kind of just smell it for when you walk in. Okay, so it's that bacterial smell, like just that growing bacteria, you can smell it. All right, so the kidneys obviously are a major homeostatic component. All right, they eliminate the waste from the blood. All right, if the kidneys start failing, we get this thing called uremia. All right, where the urea, which is all the bad products from the blood cells that group up that the kidneys are supposed to take out, stays in the blood. All right, when that stays in the blood, it becomes, I don't want to say septic, but it becomes toxic. All right, and usually you end up with some sort of septicemia, okay, or blood infection. All right, kidney stones, again, can be small, they can be large. They are most often not nice and round, okay. They often have very jagged, large razor points on the outsides of them, okay. That going down the urethra is what causes the pain. All right, it also is what causes them to get stuck into the walls of the urethra. All right, they are excruciating, obviously. Think of a giant caltrop trying to come out of your well, not caltrop, that's not the right word. What are the, well, maybe it is, like, think of a jack. All right, jacks might be a better option. Think of like a jack trying to come out of your urethra on a microscopic scale, right? So we can go into kidney failure. All right, hopefully if it's acute and it's new onset and simple, all right, we can go to the hospital, they can figure it out and they can get the kidneys restored. All right, people who end up in chronic kidney failure, all right, usually the dialysis patients or they get transplants. All right, they'll usually have a fistula or an artificial graft for dialysis treatment. Sometimes they start off with a port, hoping that they only need a couple. And if that doesn't work, they'll get the surgery in the arm. All right, if you see a graft, right, we don't do anything on that arm. No blood pressures, no IVs, nothing on a grafted arm. All right, everything's on the other side. Oh, apparently I just did this at the end instead of at the beginning. You know, I got to reorder this one. The whole the flow doesn't make sense. All right, so gynecologic problems in females obviously are an issue for acute abdominal pain. All right, especially if they're complaining of lower quadrant pain. All right, it may be any portion of the female reproductive system. Okay. No? Yeah, I really got to go through this one again. All right, I apologize. This is a horrible lecture setup. I don't know what I was thinking. Okay, other things that are in the abdominal cavity, right? The aorta, the abdominal aorta, okay. Triple A's, your abdominal aortic aneurysms. All right, they are very hard to detect. Okay, most oftentimes you will find either searing, tearing, burning, back pain sensations. A lot of times for triple A's, blood pressures on both arms, they're not going to be the same. They're not even going to be close. One will be high, normal, and one's going to be super low. All right. So if you have any reason to suspect this, all right, take a blood pressure on both sides and you can figure it out. All right. Pneumonia, again, is another one that the infection can go from the lungs down into the abdomen and cause problems. All right, so take your lung sounds. All right, if they were just in the hospital with pneumonia and they're having abdominal pain now, all right, it could have moved. So take them back to be reassessed. All right, a hernia. All right, the definition is any protrusion of an organ or tissue through an opening where it does not belong. All right, so we talked about brainstem herniations through the foramen magnum. All right, you can have other hernias of intestinals, right, through openings that happen that shouldn't be there. Okay, so anytime something goes where it's not supposed to go, all right, through a small opening is called a hernia. All right, you may or may not know, you may or may not see it. Some people have umbilical hernias. It looks like a big old bump across their belly. All right, sometimes they're fixable, sometimes they're not. Okay, strangulation is the worst. Okay, when that blood supply gets cut off to whatever part is herniated. All right, that tissue dies, we can't get it back. All right, so you got to go get it taken care of, right? It's a surgical fix. All right. Other than like an external hernia, I don't know how you're going to notice. Okay, that's going to be not something that we're going to see. All right, but it should be pretty excruciating. All right, and they should be having serious problems. You may see hypotension. All right, so if they had a mass, all right, that they could fix their own. All right, sometimes people fix their own hernias. I don't agree with it sometimes. All right, if they cannot handle it anymore, or if it now becomes no longer reducible, okay, we need to have it looked at. Any type of severe pain or tenderness, all right, or if it starts becoming discolored, right? That discoloration means something's going on. Okay, so we're gonna have it, we need to have it taken care of. All right, do we really need to go through the whole scene size up assessments of these people? Are we tired of it? Do we know it yet? Okay, scene safety. All right, why do we want a gown? Well, we're first, right? But in what instance with abdominal pain do you think we would want a gown? Or
If somebody's throwing up.
or protective covers for my shoes, right? Coughing up blood. What's that other one I told you about? Right?
Poop.
Huh? Right, diarrhea, poop. What about the guy I had in the kitchen chair? You guys remember the story? Right? The rectal bleed where he said, I got to poop. And I'm like, please don't, sir. Please, please do not. And he was like, he let it go and it wasn't poop, right? It was that river of blood that came out across, right? I don't want that on me or my shoes. Okay, so you may need a little bit more PPE for this one. All right. Again, possibly could be violent. All right. You will smell it from the door. You will know. It will smell like steel poop. All right. You'll get that irony blood smell and you'll get that strong fecal odor at the same time. And you will know the difference. All right. It will be a smell you'll remember. All right. ABCs, again, if they're bleeding out, they can go into shock, right? So they could have shallow, inadequate respirations. All right. We're going to ask about vomit or black target stools. We're going to check pulses in both arms again for AAAs. And we're going to check blood pressures in both sides if we feel that's what it is, or they tell you they have a history, or they tell you I have a AAA. All right, it's been diagnosed, but they said it wasn't too bad. I don't have to do anything about it. It might have got bad today. Okay, our transport decision is up here because we usually know almost by walking in the door, all right, whether we are going to hang around for 5 minutes or we're going to pick them up and get them out, right? So we're gonna do our sample. All right, we're gonna focus in on nausea, vomiting, bowel habits, any recent weight loss, right? Any abnormal gas escapes, whether it be belching or flatulence, right? Pain, is there referred pain, chest pain, back pain? All right, and then we'll get into the rest of the symptoms. All right, but we're worried about those first 6. Okay, then we're gonna do our physical exam. These are ones we're gonna palpate, and we're gonna palpate pretty good. All right. It says gently. All right. But I can't feel my liver just by doing this. Like, all right. When the doctor palpates you, when you say I have abdominal pain, it almost feels like he's trying to reach through to your spinal cord sometimes, right? I'm not saying push that hard. Okay. But if it's soft and tender, all right, that's good. If it's firm in places, right? Try to find out where it's firm, how far it goes, why it goes. All right. That's all things that we can tell the doctor when we give our report. All right. Vital signs are simple. Okay. And then we're going to frequently reassess, right? We're going to find out if what we're doing is good. If they're in shock, we're going to treat for shock. All right. We're going to take the patient to probably the closest facility. Okay. Because most people can handle abdominal pain problems. All right. Put them in the position that they're comfort in. Okay. Other than oxygen, there's not much we can do. ALS can do pain management, but again, if you're 10 minutes from the hospital, I'm 20 minutes away, don't wait for me for morphine. The morphine is closer. All right, take them to the hospital. Okay. For whatever reason, you feel like you can't get them up because they're in so much pain. I don't know. You decide. All right. Sometimes you just got to tell them to grin and bear it. Get up and let's go. Okay. Again, watch out for shock, treat for shock. Okay. Low flow oxygen, all right, may decrease a little bit of nausea. We're not going to pump them full, right? We don't want that abdominal distension. Okay. We don't want to cause any more additional nausea. All right. Make sure you clean up really well. You don't want blood / poop / anything else on your stretcher, right? Dialysis. Okay. These are very special patients. All right. Most oftentimes, if you get called for them, it's going to be from the dialysis center. They're either going to be hypotensive because they took too much fluid out. All right. So what they do is they hook you up and they basically filter all of your blood through a machine through that graft. All right. There's an in port, there's an out port. It takes the blood, it filters it, it puts it back. All right. Basically, they're taking fluid and other things out of your blood, and they take so much. All right. Because they don't want to crash your body. That's why you go 3 times a week. All right. It's not something you can do in one day. All right. So some people, we will take them. Okay. If they are unable to stand on their own. All right. If they're bedbound, we will go to their house, pick them up, take them into dialysis, put them in a dialysis chair. When they call us back in 4 hours, we go back, we get them. Most times they're on oxygen. All right. We're going to assess them like we assess any other patient. Okay. If they tell you they have any abnormal symptoms that day, they have a fever, something's going on, right? Their heart rate's like 130. All right. These are things that you should call the doctor, call a dialysis center, because they usually have a book with a number, and be like, hey, John is tacking away at 150 today. Do you want me to bring him to dialysis, or should I take him right to the hospital? Okay. Because more often than not, they're going to take their vitals. They're going to be like, yeah, I don't think he's stable enough for treatment today. And they're going to call the ambulance and have you take him in anyway. All right. And the only place that does dialysis around here is Vassar. Okay. So all these people have to go to Vassar for in-hospital dialysis treatments. All right. Again, be careful of the graft. The graft is highly vascular. People can bleed out from the graft. Sometimes they mess up when they're taking the needles out. All right, they'll start hemorrhaging from the graft site, and they may call you for that. Don't tourniquet it, okay, but try to do the best you can to slow that bleeding down. All right, and then get them to the hospital, because again, it's surgical and they have to fix it, right? It's literally, they take an artery and a vein and they sew them together. All right. Most times it will continue to bleed. Yeah. So you're just going to do the best you can, wrap it up, put some pads on it. All right. Try to stop it the best you can. But again, we're not going to squeeze on it. We're not going to push on it. We're not going to tourniquet it, because you don't want to cause any further damage to the graft. All right. Unless it's like a full rip. I mean, I'll pull up a picture. Yeah. You'll know when you see it. It is. Okay. So high flow oxygen, manage bleeding the best you can, manage shock if they're bleeding out, obviously, and go, right? Just most dialysis places are close to a hospital. All right, that you don't have to worry too much about where you're at and what's going on. All right, so you guys are probably just seeing that one. So let me stop that share. Let me share this one. All right. Okay. So you guys on Zoom should see the Google, right? What did I just say? Dialysis. Images. All right. So they kind of look like that. That one's kind of a little aggressive. All right, but there's some form. Okay. That looks great. People on Zoom can see it. All right, stop. It's right in the middle of the screen. You can't see it? Stop. All right. How about that? Does that look better? Huh? Yeah. Okay. So that's an aggressive one. I haven't seen one that looks like that in a while. Usually you have just this first bump up here. I don't know what that one is there. That one looks a little bit separated. Okay. Usually they'll put both graphs next to each other. That looks like the entrance is on one side and the exit's on the other. Let's put that on the bottom so I can go back. All right, this is kind of a more common one. All right, sometimes it's farther down in the forearm, but they're usually right next to each other. Yeah, they're always in the arm, I think. All right, that's more of a standard. Someone who's been dialyzed a bunch. All right, they're usually all bruised up. Okay, it's usually you want to think of it like a log up, a subdermal sausage. All right, basically. Okay. But I have never actually tourniqueted one. I really wouldn't, because the vasculature is so frail, that you may cause more damage. All right, so basically, right, they graft the artery and the vein together. Okay, and then the catheter comes in through the graft. All right, and they put the needle in and they draw it out and put it back. All right. I mean, I've never heard anyone who was excited to go dialysis. It's a needle every 3 days because they got to poke through the skin. There's no external port. Okay, so I mean, I'm not a dialysis expert, but by any means. All right. So those are okay. So that's the machine, right? So the two needles that go in, one out, right, through the graft. Okay, and it's basically like a external circulatory machine, and it filters out all the toxins from your blood. Okay. Any other questions on grafts, on fistulas? Yeah, these are what they look like when they get older. Okay. This is the normal one you'll probably see most often. But yeah, no, they're what if they don't have arms? They'll usually have like a subclavian port. Yeah, it does that. So So that's well, okay, but that's someone who is new and who is starting. Okay, they'll start this way. All right, and then these are very hard to keep clean. All right, they will often get infected. Most people don't clean themselves very well or clean around the incision site very well. All right, so a lot of people will get septic. Even regular people who have ports or some sort of external venous access, a lot of times when they aren't feeling well, okay, always check the port site, see if it's infected. All right, sometimes things happen. They don't get cleaned out properly. All right. But yes, that's the start of it. All right, and there's an arterial and a venous clamp. They hook right up to them. Okay, this is the much easier option, but it's not a long-term option. All right, this is what it looks like on someone's chest. Okay. All right, that's what it looks like when they get infected. Okay, so you're looking for that red, all right, that red swollen, possibly discharge, pus discharge. Okay. So we don't take the port out, obviously, like this picture. No, they should be secure. They're never going to be hanging like that. It'll be under a bandage. All right, these are people laying in a hospital bed probably for picture sake. Okay, there also is a thing called peritoneal dialysis. All right, so they can stick a tube. These people do it at home. All right, it's usually in the abdomen somewhere. There's usually a jug of fluid up here and like another jug, and they kind of wash themselves out. Okay, that's very rare. You come across people who do that nowadays, but just be aware, you may see it. All right. And then for those of you who feel left out, okay, we'll do the female. Well, the diagram is on eBay. Yes. All right. So the uterus, or the ureters come from the bladder up top. All right. Your uterus is sandwiched, all right, between your bladder and your rectum, right? It's a nice little small, stays small, kind of stays in that position until it's necessary to be used. All right, then it'll grow. Usually grows outwards and upwards. All right, the cervix is the little bottom portion of the uterus down there. Okay, stays open and closed depending on what cycles are in. The ovaries are up top. All right, the fallopian tubes are not connected to the ovary. They sit right outside. The egg is released. They feathery, nice, try to catch them, drop them in the fallopian tubes, right? They get brought down to the uterus, they get fertilized. All right. The bladder sits in front, up by the pelvis, up by the pubic bone, okay, which is why when women get pregnant, all right, all of that gets squished, all right, that space doesn't grow, right? So that uterus grows, all right, but it pushes on the rectum, it pushes on the intestines, it pushes on the bladder. It's why they have to pee every 10 minutes, okay? Sometimes they have leakage because it's just pressure pushes against the bladder and it leaks out. All right, you have the clitoris above or just below the pubic bone. All right, you have the urethra, which is just below that. All right, there's usually a couple labium. You have the minora and the majora. All right, the external ones. This is what in men folds down and becomes the scrotum. All right, guys, if you ever notice that seam right down the middle, it is the fusion of the external labia of a female. All right, we're all born female. Okay, until our scrotum fuses. All right, that's the labia fuses together. Joe's looking at me like I'm a weirdo. All right. Unmute. Oh, you're all still here. Good job. All right, so we're gonna go over the quiz real quick and then we're gonna be done. All right, so let's go over the GI quiz. Unless anybody has questions on the on the neurology quiz, and then we'll do that too. But you guys let me know what you want to do. Nope, we're not that far yet. Allergy, that's next week. Gastro, there we go. GI. All right, let's go paper quiz. No. There we go. Quiz with key. All right. Is there any specific question you guys want to go over? Or you just want to go over the whole thing? How about you guys online? Any specific questions, or you just want to go over the whole thing? Anybody? Everybody left? No one's listening anymore?
I don't have anything specific. I'm good to
Okay.
go over everything.
All
I
right.
was about to say I don't have a preference either.
All right. We'll go in order then. All right. So 60-year-old female presents with tearing sensation in her lower back. Okay. Skin is sweaty. She's tachycardic. EMT should suspect what? Anybody just shout them out, because I can't, it's not like Zoom where we can go one-on-one. Right. Aortic aneurysms, right? We talked about it. Okay. This is that searing, tearing back pain. Okay. Strangulated hernia is one that, what do we think? Am I even sharing my screen? You guys are probably, why doesn't no one tell me I do these things? You guys are just going along like like you can see what's happening. You guys in Zoom gotta speak up. All right, can you guys see the screen now?
Yeah. It's just
Okay.
hard to what's intentional sometimes on Zoom.
Well, if I'm reading something and you can't see it, then it's obviously intentional. I'm trying to share something with you. All right, just speak up. Even if it doesn't seem like it's right, just ask. All right, because I can't see you and I can't see your confused faces like I see Joe every 5 minutes when he's looking at me weird. All right, so strangular hernia is what?
See?
Loses blood supply due to compression of the local tissues. Yep. All right, chronic renal failure is a condition that occurs from conditions such as dehydration, can be reversed, causes dehydration from excessive urination, or caused by hypertension or diabetes. What'd you say, D? Right, caused by hypertension or diabetes. Okay, those two will lead to kidney failure. Right, erosion of the protective layer of the stomach or duodenum secondary to overactivity of digestive juices results in
D.
ileus, appendicitis, cholecystitis, or an ulcer. Right, it's an ulcer. Esophageal varices most commonly occur in patients who, right, consume a lot of alcohol. All right. Most patients with abdominal pain refer to or prefer to lie on their side in the prone or in the fetal position, right? It's basically what that is. Lie with their knees flexed, sit upright because it relaxes the abdominal muscles, or sit semi-fowler with their knees slightly bent. Right? Most people are A, they're gonna lay in the fetal position, right? For whatever reason, that seems to help. Okay. Pain may be perceived at a distant point on the surface of the body, such as the back or shoulder, is called what kind of pain? Right, referred pain. Okay. Pain that radiates to the right lower quadrant from the umbilical area, nausea, vomiting, and lack of appetite are indicative of pancreatitis, appendicitis, gastroenteritis, or cholecystitis. Right, appendicitis. Right, lower right quadrant. All right, everyone should get this one right because we all had a test on it. Solid abdominal organs include, right, what is it? C, the spleen, the kidneys, and the pancreas. Right, the bladder. Anything that says bladder is a hollow organ, gallbladder, regular bladder. So if the bladders, if you see the word bladder in any of the answers, that's obviously wrong. And the stomach, you might as well just call the food bladder, right? So the only one it could possibly be there is C, right? Kidneys help regulate blood pressure by eliminating toxic waste, retaining key electrolytes such as potassium, accumulating a large amount of blood volume, or removing salt and water from the body. Right, removing salt and water from the body, okay? Huh? So, go ahead. Right. So excess salt will cause hypertension due to the calcium, potassium, sodium ion pump, right? If you really want me to get into chemistry and explain how the heart works. All right, there are three ions, calcium, potassium, all right, and sodium that cause the heart to do what it does based on the concentrations of each one in the muscle. Okay. So too much sodium, all right, will raise your blood pressure because it's going to mess with the stroke volume of that cardiac output thing. All right. And water is just volume. All right. That's the volume part of the blood, right? So if you put more water in, you put more fluid into the blood, right? It's almost like me giving someone fluids, right? If I give someone a bag of fluids, their blood pressure comes up, right? Because I'm adding more water to the system. Okay. The pump's pumping, but it's pumping more water through. No, it's not. All right. But it does. And that's what they're asking you. They're asking you how the kidneys help affect your blood pressure. No, you get multiple organs do multiple things. Okay. It's not the only one, but they play a role in it. Yes, no, maybe. Right, that's not gonna do anything about the blood pressure. That's gonna keep you from being sick, right? Because it's gonna take those toxins out and not have them build up in the blood. Right, so you won't. Well, water is the easy one. Like I said, just think of giving someone a bag of IV fluids, right? If they're hypotensive and I give someone fluids, their blood pressure comes up, right? Because we're adding more volume to the pump. We're adding, right? And that cardiac output. No, it's not. It's not the same amount, right? But we're filtering all that stuff through. Okay. Right. So your kidney is regulating your water consumption, right? Because it's going to take it out and it's going to filter it and it's going to take that water out and create urine, right? The urine doesn't just magically show up, right? The kidneys have to take water to create that urine. You can't just, right? The urine is just a vessel, that water for the toxic stuff, the urea and all that other stuff to come out through. But your body just doesn't magically create water in the bladder, right? Your kidneys take that water and then it adds the stuff to that water, right? And then you urinate. But it does, right? Because you're removing volume from the bloodstream. You're taking, right? Is there some other way I can explain this that makes sense? Do you understand? Like, I'm trying to figure out a way to explain it, but I don't know. Right? It's a volume. Like, remember we said there's three parts. You got the pump, the plumbing, and the actual volume, the fluid, the liquid. Okay. Well, the kidneys are working on that volume part of that. Okay. And they're working on the pump through the sodium. Okay. In ways that we're not going to explain because it's going to confuse you even more. Sometimes it's, they'll give you a diuretic. My grandmother was on a Lasix pill. Okay. The water pill, the old people call it. All right. They're trying to regulate your blood pressure through possible other means like metoprolol. I don't know, there's like 6 other ones that I can think of. Yes, because for some reason your kidneys are either not taking enough off or you're storing more, you're getting that edema in the legs. Okay, they're, you know, so in order to take some pressure off of the kidneys, right, we're going to give them that diuretic that Mark talked about. Okay, but just remember the body is 3 main components, right? The pump, the plumbing, and the fluid. Okay, and any one of those 3 things will regulate your blood pressure. All right, so volume is one of them. All right, most common and significant complication associated with acute abdomen is what? Pain, bleeding, fever, or peritonitis, right? Peritonitis, the inflammation. Okay, I would almost say bleeding should be worse. Okay, but peritonitis could be because something's in there causing that problem, right? It could be something ruptured, something's leaking. All right, we're going to worry more about sepsis, I think, at this point, than we're going to worry about bleeding. All right, I would give you credit for either one of those. So if you put B, and maybe I'll go back and look. So remember, we talked about acute abdomen is any sudden onset abdominal problem. Acute just means sudden onset. All right, so I'm standing here right now, all of a sudden I double over in pain and start crying and say my stomach hurts. Okay, that's acute abdomen. All right, someone who has, you know, a history of cholecystitis or has their gallbladder removed, or someone who has GERD, okay, they have history, all right, they have chronic abdominal problems. Someone who has Crohn's disease, diverticulitis, diverticulosis, someone who has an ostomy bag, all right, those are chronic abdominal conditions. But if you have sudden onset abdominal pain, right, that's an acute abdominal problem. All right, they just don't want to say so many words, so they break it down to an acute abdomen. Okay. The parietal perineum lines the surface of the organs, the retroperitoneal space, the walls of the abdominal cavity, or the lungs and chest. Right. Obviously, the parietal is the outer lining, right? Huh? And visceral does the organs. Yep. The principal system in both infectious and non-infectious gastroenteritis is fever, dysuria, vomiting, or diarrhea. Diarrhea. Yep. So that gastroenteritis is usually the lower half. All right, so it's mostly diarrhea. You may have some vomiting involved, but it's mostly going to be the best answer is diarrhea. Which of the following conditions is more common in women than men? Cholecystitis, cystitis, pancreatitis, or hepatitis? Cystitis, right? Which of the following is characteristic of peptic ulcer disease? Burning or gnawing stomach pain that subsides immediately after eating, symptom relief after taking non-steroid or NSAIDs, the passage of bright red blood in stool or coughing up blood, sharp pain typically located in both lower quadrants. Right, burning or gnawing stomach pain that subsides immediately after eating. Okay, which of the following organs assists in the filtration of blood, serves as a blood reservoir, and produces antibodies? Kidneys, liver, pancreas, or spleen. Right, this is the spleen. Okay. Which of the following organs lies in the retroperitoneal space? Okay, so it's not outside, right, the peritoneum, but it's in the retroperitoneal space. All right, this is the one, right? You guys were, this is a question you had? Okay, so, all right, let's go. Okay. This one showed a little bit better. Fascia, the posterior parietal space in the back, the retrorenal anterior. Okay. Right, so this is the back, right? So the retroperitoneal is outside, it's behind, right? So it lies between the sublumbar and the peritoneum. All right, so it lies between the back and the posterior side of the peritoneum, right? So basically, if you take all of the abdominal organs out of the cavity, okay, take all that stuff in front, that's the retroperitoneal space, is what's behind it. Okay, so it's your kidneys, your ureters, all right, your bladder, all that stuff behind it. Okay, this brown stuff right here, okay, I know you can't see it, but this is it says the peritoneum covering the posterior abdominal wall. All right, so this is your parietal peritoneum that everything's attached to in the front. Okay, so there's a space in between that and all of your circulatory system and your renal system. Okay, so what lies behind that, but in between that and the muscular part of your back. Okay, because the muscles are what support the back. All right. And now the pancreas shouldn't be there, right? The pancreas isn't in the retroperitoneal space. It should be the kidneys. Oh, is it behind it? Are we calling that yellow thing in the middle of the pancreas? This right here? Okay. I mean, I'll believe the doctor. Okay. I didn't know the pancreas hung outside or inside there. I thought it was just the kidneys. All right. So even I learn something every day. That's probably the pancreas too. And this one over here, this yellow feathery thing right here, that's probably the pancreas. All right. So yeah, I mean, seems like that's the only answer. If the kidneys were up there, I would have given you credit for the kidneys too, but pancreas, gallbladder, spleen, liver. Yeah. So out of all that, I guess the pancreas is the right answer. So he's like in a normal abdominal diagram, it always shows the pancreas just under the stomach. So it's kind of misleading. Every diagram you've ever looked at, right? They're kind of bringing the pancreas to the forefront so you can see where it is in relation to the stomach, but it's behind that brown lining that we showed, right? So yeah, it's a little misleading. Okay, like you don't even really see it in this diagram, like he said. Okay, but it hides behind that brown lining in that retroperitoneal space. But like when they show you the diagram, they want you to see in relationship where it is in relation to everything else, I guess. All right, but it's not in the same plane. Okay, that's a bad question. I don't really like that question. I understand it, but yeah, I mean, like you said, it basically leads you to believe that every diagram you've ever seen of every human being is now wrong, right? So which of the following organs is the most likely to bleed if injured? All right, which one is the most vascular here, right? The liver, okay. Which of the following statements regarding the acute abdomen is correct? The most common cause is inflammation of the gallbladder and liver. Almost always occurs as a result of blunt solid trauma. The initial pain tends to be vague and poorly localized. The parietal is typically the first abdominal layer that becomes inflamed or irritated. Right? The initial pain is usually vague and poorly localized. Okay. Usually takes a little bit for the abdomen to like ramp up for people really to have an issue to call 911 with, right? They're usually not calling because it aches, like a stomach ache. All right. Your patient's past medical history includes hypertension, congestive heart failure, diabetes, and seizures. Holy cow, what's left? Today, he presents with signs of renal failure. Which of his medical problems most likely caused this? All right, the heart failure. Okay. So why is it the heart failure? All right. I mean, it can be literally almost any of the other ones but seizures, right? But why is it mostly the heart failure, right? What does heart failure cause? All right, especially what does left-sided heart, no, right-sided heart failure cause? Edema, right? So now where there's more fluid in the body, all right, the body is not eliminating this fluid properly. Okay, now we're storing it. Now the kidneys are overtaxed and overworked because it's got to filter more. All right, and it's not really doing its great job. Okay, because we're still storing more and more fluids. All right, we're not getting rid of them somehow. All right, so eventually, okay, the kidneys are going to start failing as well. Yes, no, maybe. Joe's got the confused look on his face. He's thinking about like whether I'm right or wrong. Huh? Yeah, well, that's why most of these people have diuretics. All right, people with CHF are given diuretics so they pee more, so that they get rid of that fluid. Okay, so they don't go into kidney failure.